Good evening, everyone. Shall we start?
Nilina,
Yes.
3 minutes.
Okay, we'll wait for 3 more
36
minutes.
seconds.
Yeah.
Okay. Nilina?
Yes. Shall we start?
Yes.
Good evening, everyone. Welcome to yet another session of the Rapid Review series by ASMIC. The session for today is being handled by Dr. Gina Sebastian. Madam is a professor and head of Mahi Institute of Dental Sciences and Hospital, and she has completed her graduation and post-graduation in oral medicine and radiology from KVG Dental College, Sulia. And she is also certified in tobacco counseling and pharmacotherapy. Madam has various national and international publications to her credit. I welcome Madam for the session.
Thank you, Nilina, for the introduction. And good evening, everyone. Good evening, Diva ma'am. And I wish all of you a great Valentine's Day. And I hope everyone has enjoyed and being enjoying. I think the number is less because of this celebrations going on. Then
Thank you, ma'am.
Shall we,
Yes,
shall we start?
Yes.
Is it visible?
Yes, ma'am.
Okay. So today's topic is white lesions of the oral cavity. So, based on the question paper, these were the questions which were asked. That is, classify white lesions of the oral cavity, oral submucous fibrosis, lichen planus, candidiasis, leukoplakia, lichenoid reaction, hairy leukoplakia, nicotine stomatitis, chemical burn, non-keratotic white lesions, and scrapable white lesions. So, n number of questions were asked in this section. And multiple times, these classification OSMF, lichen planus, candidiasis, and leukoplakia was asked in various universities and multiple times. And I think OSMF, lichen planus, candidiasis, or leukoplakia, all these potentially malignant disorders were covered during the previous sessions. So, as we all know, diagnosis is the key for the success of treatment outcome. So, as dental surgeons, it's our responsibility to properly diagnose and refer in needy cases. And this initial or early referral is very, very important because it may improve the morbidity and mortality of the patients. So coming to color of the oral mucosa, the color of the oral mucosa, as we all know, it is pink in color. So what are the reasons for white color of the mucosa? Again, this is a Viva question for you. The reasons are because of the surface changes, changes in the epithelium, and submucosal changes. So what are the surface changes? The changes may be due to surface debris, as you see in adherent food particles, then fungal colonies, as you see in candidiasis, fibrin exudate, that is a pseudomembrane covering over the ulcer. These are the surface changes you see. Then coming to changes in the epithelium, you have epithelial hyperplasia as seen in verrucous carcinoma, thickened layer of keratin in traumatic keratosis, intracellular edema between the epithelial cells as seen in leukedema, submucosal changes that is due to the reduced vascularity of the connective tissue layer seen in oral submucous fibrosis, and submucosal deposits seen in amyloidosis. So these are the changes seen, and because of these changes, the color of the mucosa appears white. So again, to repeat that, there may be surface changes due to increased keratinization, coagulation, necrosis, and deposits. Then intraepithelial changes, that is acanthosis, atrophy, erosion, or ulceration, and connective tissue changes, that is inflammation and fibrosis. So because of these, the color of the mucosa becomes white. Now, for your question, what are the white lesions of the oral cavity? And this is a classification that is given in Burkitt's 13th edition. So based on the scrapability test, it can be keratotic white lesion and non-keratotic white lesion. So keratotic lesion again can be classified as with known malignant potential and without known malignant potential. So with known malignant potential, you have these classification, that is leukoplakia, OSMF, lichen planus, lichenoid reaction, actinic keratosis, chronic hyperplastic candidiasis, DLE, disc keratosis congenita. And with without known malignant potential, we have traumatic keratosis, nicotine stomatitis, oral hairy leukoplakia, oral genodermatosis, psoriasiform lesions, focal epithelial hyperplasia, intraoral skin grafts, intraoral scar, and non-keratotic white lesions. You have pseudomembranous candidiasis, Koplik spots, diphtheritic patch, syphilitic patch, enek, Morsicatio baccarum, uremic stomatitis, and radiation mucositis. So for your exam point of view, this classification is very, very important because white lesions was asked in several question papers. Then scrapable lesion was asked, keratotic lesion was asked, and non-keratotic lesions were asked. So if you study this classification, you can answer all these 4 or 5 questions. Now there is a separate another classification, that is white lesions can be classified as congenitally or genetic lesions and acquired lesions. And genetic lesions you have, leukemia, hereditary benign intraepithelial disc keratosis, and the acquired lesions can be scrapable lesions and non-scrapable lesions. Scrapable lesions, again, it can be superficial oral burn, pseudomembranous candidiasis, pseudomembrane oral ulcers, morsicatio, and acquired lesions with specific pattern and without specific pattern. With specific pattern, there are certain lesions which have a specific pattern like lichen planus, lichenoid reactions, and lupus erythematosus. And without specific pattern, you have frictional keratosis, leukoplakia, verrucous leukoplakia, OSCC, verrucous carcinoma, nicotine stomatitis, actinic cheilitis, chronic mucocutaneous candidiasis, chronic hyperplastic candidiasis, and others. So you have to study this classification, either the Burkitt's classification or this classification. Now coming to the lesion, the first lesion is leukedema. That is, it is higher prevalence among blacks and is due to more mucosal pigmentation, making this condition more apparent. And this leukedema is present most, and it is more distinct in smokers. But after smoking cessation, it becomes less obvious. So what is the pathognomic feature of leukedema is a diffuse gray to white non-scrapable veil-like condition, and which disappears on stretching. That is the most pathognomic feature of leukedema. It is a veil-like grayish-white opalescence which disappears on stretching. So you can see this picture. There's a grayish-white opalescence, and when you manipulate with a mouth mirror, it disappears on stretching. Next is linea alba. You can see it's a prominent horizontal white line that is seen in the buccal mucosa along the occlusal plane. You can see these pictures, and that is more prominent in patients or persons with habits like parafunctional habits like bruxism and clenching. The next is Fordyce's granules. So Fordyce's granules, as you all know, these are yellowish white papules that are present on the buccal mucosa. These are due to ectopic sebaceous glands. Ectopic means that is present at an unusual site. You all know that sebaceous glands are present on the skin. So Fordyce's granules are due to the presence of ectopic sebaceous glands. Coming to white spongy nevus, this is an autosomal dominant inherited disorder. It is also called as Cannon disease. And we can see the intraoral lesions that is symmetrical, thickened, white, corrugated or velvety plaques of variable size with an irregular and fissural surface. So these are all hereditary diseases, white spongy nevus or Cannon disease. And the buccal mucosa is affected and most commonly bilateral. Other areas which are affected are ventral surface of the tongue, labial mucosa, soft palate, alveolar mucosa, and floor of the mouth. And when it affects the esophagus, it causes dysphagia. Now coming to oral burn, which is a common condition which while you see in the patients in clinics, that is, you have thermal burn and chemical burn. Thermal burn, it is due to ingestion of hot foods or beverages like hot pizza or coffee. And it might be due to cold food also like popsicles. And if it is mild, it affects a small area and a sloughy yellow-white necrotic epithelium with areas of erythema and ulceration can be seen in thermal burn. And chemical burn is seen in medications to relieve dental pain. And also the documented caustic materials are aspirin, and the clinical appearance is mucosal necrosis, and the superficial mucosa becomes white and wrinkled and also causes denudation of the epithelial layer and a yellowish fibrinopurulent membrane over the area. So all these cases, you can see the tissue tags which are easily scrapable. And the treatment includes non-steroidal anti-inflammatory drugs, antibiotics, antiseptic mouthwashes, and coverant with a protective emollient paste or hydroxypropyl cellulose film. So next is morsicatio. The word meaning morsicatio, morsus meaning bite, which is also called as morsicatio mucosa oris or chronic mucosal chewing. So these lesions are self-induced injury and chronic tissue irritation like habitual chewing of the buccal mucosa. And these conditions are more common in elderly patients and in patients are those having more stress or mental illness. And the most affected areas are the epithelium of the buccal mucosa, and that is called as Morsicacia buccarum. And when it affects the lips, it is called as Morsicacia labiorum, and the lateral borders of the tongue, that is Morsicacia linguarum. Here you can see in this picture, you can see the shaggy and thickened macerated grayish white patches or plaques with keratin shreds, tissue tags or desquamated areas. And this peeling of the irregular rat surface causes erythema or erosion, but not ulceration. This is a tobacco-related lesion, that is a tobacco pouch keratosis. You can see the keratinized area of the mucosa as well as wrinkling of the mucosa where the patient keeps a quid there. So high consumers display a white and leathery lesion which sometimes contain ulceration. Gingival retractions are the most common adverse reactions because these are irreversible. The gingival retraction, once they happen, it is irreversible, whereas a mucosal lesion regress with a couple of months. So ask a patient to quit the habit. So next is frictional keratosis. It is a benign lesion that develops due to chronic mechanical irritation of the oral mucosa that leads to localized thickening of the keratin layer. So that is a body's defense mechanism. When a trauma appears, the body's defense mechanism, there is a abnormal or there is a thickening of the keratin layer, abnormal deposition of the keratin layer, and that is a protective response by the tissue rather than a precancerous or malignant condition. So this is a rough and slightly elevated patch that is seen in the edentulous ridge in subject to mechanical stress. Next is hairy leukoplakia. That is the second most common HIV-associated lesion, and that is associated with Epstein-Barr virus. It is most common on the lateral borders of the tongue. It appears as vertical white folds oriented as palisade along the borders of the tongue. White elevated plaque which cannot be scraped off. So the differential might be leukoplakia. So how do you diagnose it? But based on the clinical characteristic, then detection of Epstein-Barr virus. Usually, no treatment is required since asymptomatic and shows spontaneous regression. But if the patient is symptomatic, then antiviral medication should be given. So this is very important, the lichenoid reaction. This is asked as a short note for you. Lichenoid reaction, there are three types. That is drug-induced lichenoid reactions, lichenoid contact reactions, and lichenoid reactions of graft versus host disease. So first is drug-induced lichenoid reaction. It is a delayed hypersensitivity reaction. It is mainly due to drugs like penicillin gold, NSAIDs, sulfonamides, and antihypertensives. And the lesions comprise a white reticular or papillar area with an ulcerative reaction pattern and usually unilateral. And how do you recognize it? Discontinuation of the drug causes resolution of the lesion, or you can symptomatically treat with topical steroids. Next is oral lichenoid contact reaction. It is again a delayed hypersensitivity reaction to constituents derived from dental material. As you see in this picture, you can see the white plaque-like lesion that is present on the buccal mucosa in close proximity to the amalgam restoration. So it is asymmetric and unilateral. Buccal mucosa and lateral borders of the tongue are involved, which is in close proximity to the restorations. And it might be also due to hypersensitivity to dentifrice and chlorhexidine. And the lesions resolve within 2 months following the replacement of the restorative material. It is also common in composite restorations now. So you can see the anterior aesthetic restorations when they are placed, the lichenoid reactions can be seen on the upper or lower lips. So that should also be considered when deciding a treatment plan. Then third one is lichenoid reactions of graft versus host disease. So this occurs in 15 to 30% of patients who survive 3 months after transplantation. And it is seen both in acute and chronic graft versus host disease. And the lesions are indistinguishable from lichen planus clinically and histologically. But these type of lesions has got a widespread involvement of the oral mucosa. And in these conditions, opportunistic infections like candidiasis should also be considered. And the importance of these lesions are that these type of whitish plaque-like lesions may resemble leukoplakia, and these leukoplakic lesions have chances for oral malignancy. So regular follow-up should be needed for these lichenoid reactions of graft versus host disease. Now, coming to candidiasis, candidiasis, it is the most prevalent opportunistic infection affecting the oral mucosa. So this has already, I think it has been already discussed. So in white lesions, there are two most common type of candidiasis, that is the acute pseudomembranous candidiasis and chronic hyperplastic candidiasis. So what are the predisposing factors? Acute and chronic diseases like tuberculosis, diabetes mellitus, myxedema, Addison's disease, hypoparathyroidism, immunodeficiencies like HIV, nutritional deficiencies like iron, vitamin B6 deficiency, then prolonged hospitalization, prolonged use of antibiotics, corticosteroids, then use of intravenous tubes, catheters, heart valves. So a proper history should be taken before seeing that patient. A proper history should be taken, whether the patient is taking any drugs or the patient was hospitalized for any serious illness. So this is acute pseudomembranous candidiasis. That is the most common form of candidiasis. It is also called as oral thrush, and it occurs in neonates as well as in adults. So when it occurs in infants, the oral lesion starts between 6th and 10th day after birth, and it is mainly contracted from the maternal vaginal canal where the Candida albicans flushes during pregnancy. How does it appear? It appears as a soft white or bluish white adherent patch on the oral mucosa, and that may extend to the circumoral tissues. It is usually painless and it is noted on careful examination. The differential we can give as food debris or curdled milk. In adults, it is mainly seen in females, and the sites are most commonly the buccal mucosa, dorsum or tongue, palate, gingiva, floor of the mouth. And it is usually following antibiotic therapy or immunosuppression, and also seen in debilitated or chronically ill patients, as we have already discussed. And there will be burning sensation and dryness of the mouth. And how it appears is it appears as a soft, creamy, white, yellow elevated plaques that are easily scrapable. So these lesions are easily scrapable and leaves an erythematous or ulcerated surface which might be tender. Now coming to chronic hyperplastic candidiasis, that is all called as candidal leukoplakia. That's an older term. Why it is called as candidal leukoplakia is that it is a white plaque which resembles leukoplakia and which is non-scrapable. So this is the only form of candidiasis which is non-scrapable and which has a tendency for malignant transformation. So what is the etiology? Again, iron folate deficiency, defective cell-mediated immunity, and a positive correlation between this candidiasis and epithelial dysplasia has been observed. So continuous monitoring is needed. It occurs in men of middle age or over. Majority are chronic smokers, and buccal mucosa, lips, tongue are involved. The lesion, it might be homogeneous or speckled. Firm and white leathery plaques are found. The lesion persists without any symptoms for years and doesn't rub off with lateral pressure. So it is a non-scrapable lesion that you should not forget. So differential diagnosis of candidiasis, chronic hyperplastic candidiasis is plaque type of lichen planus and leukoplakia and hairy leukoplakia. In plaque type of lichen planus, we can see the Wickham striae. Then hairy leukoplakia, it is most commonly seen on the lateral borders of the tongue. And leukoplakia, you have to take a proper history. So now going to the treatment of candidiasis, there is topical and systemic antifungal medications. Topical, we give nystatin, amphotericin B, clotrimazole, and systemic, we give azoles. It is ketoconazole, fluconazole, and itraconazole. So again, after candidiasis, discoid lupus erythematosus, it is again a short note for you. So the short notes, discoid lupus erythematosus, candidiasis. Then we have discussed lichenoid reaction. This was also a short note for you, which was asked in various universities. Now, discoid lupus erythematosus, it is a classic prototype of an autoimmune disease. And there are certain environmental factors which aggravates the disease, that is sun exposure, drugs, chemical substances. So what are the features? Burning sensation, photosensitivity, dryness, tenderness, and pain. But the lesion can also be asymptomatic. So what is a typical appearance is that a white striae with a distinctive radiating orientation, which is sharply terminate towards the center of the lesion, which has got an erythematous pattern. So central erythematous pattern and radiating striae. So you have a typical honeycomb or brush border appearance. The sites are mainly the hard palate, buccal mucosa, gingiva, and tongue. So this is a lesion that is present on the buccal mucosa. Central erythematous lesion and surrounded by hyperkeratotic papules or radiating striae. When it involves the lips, it may spread to the adjacent skin, obscuring the vermilion border. Desquamative gingivitis can be seen, and with healing, erosive lesions may leave post-inflammatory pigmentation. The same can be seen in lichen planus also. So the differential for DLE is lichen planus or lichenoid reaction. So topical treatment is the first line of treatment, that is topical corticosteroids can be given. Then calcineurin inhibitors and intralesional injections of corticosteroids is useful depending upon the lesion. The next white lesion which we have to discuss is geographic tongue. Again, this is a viva question. It is also called as benign migratory glossitis. It affects the dorsum and margins of the tongue. The prevalence of the disease decreased with age with spontaneous regression of the over the time. So you can see this picture. You have an erythematous lesion or depapillation of the papillae and surrounded by hyperkeratotic margins. Circumferentially migrating, that is why it is called as benign migratory glossitis, and leaves an erythematous area behind reflecting atrophy of the filiform papillae. The peripheral zone disappears after some time and that healing of the depapillated area starts. And this disappearance of this peripheral zone suggests that the mucosa is recovering. It might be single or multiple, aggravates during stress, and usually it is asymptomatic. The patient doesn't know. When we clinically check only, we will see the geographic tongue. But sometimes the patient will have smarting sensation. So in most cases of geographic tongue, we will have fissure tongue also. So when observed in other sites, it is not present in, it is not only present on the tongue, it is present on other sites such as buccal mucosa. It is known as geographic stomatitis. So treatment is proper information of the benign character of the lesion. And if the patient has got any symptoms like burning sensation, a topical anesthetic can be given. So again, smoker's palate is a short note. It is also called as stomatitis nicotina. The common effect of smoking, you have two major effects. That is, one is smoker's melanosis. You have dark brown pigmentation of the mucosa. And the next one is white leathered lesions of the palate. That is called as a smoker's palate. Initial lesion, that is an erythematous lesion, followed by whitish palatal mucosa that reflects the hyperkeratosis. And red dots can be seen. That is, the orifice of the accessory salivary glands are enlarged. That is the red dot. Erosion or ulceration can be seen in reverse smoking smokers. And this etiology is related to the high temperature rather than the chemical, not because of the particularly because of the chemical composition of the smoke, but because of the high temperature of the smoke. So this is a classification that is given in Burkitt's 11th edition. It is not given in 12th and 13th. So Greenberg et al. Has classified smoker's palate into 3 grades, that is grade 1, grade 2, and grade 3. Grade 1 is mild, consisting of red dot-like opening on the blanched area. Grade 2 is moderate, characterized by well-defined elevation with central umbilication. And grade 3 is severe, marked by papules of 5 mm or more with umbilication of 2 to 3 mm. So this is how you grade a smoker's palate. So when you are writing the short note, you include this classification also. So this is a picture showing keratinization of the palate and also the red dots that shows the inflammation of the accessory salivary glands. So in nutshell, sorry. You can see what are the lesions, congenitally or genetical white lesions. You have leukedema, white spongy nevus, dyskeratosis congenita, hereditary benign intraepithelial dyskeratosis. So we have discussed leukedema and white spongy nevus. Then dyskeratosis congenita, you can see the bullae formation with erosions and leukoplakic lesions. Then HBID, it is seen in childhood, a pallescent appearance mimicking leukedema. These are the congenital lesions. Now coming to acquired white lesions that can be scraped off, superficial burns, pseudomembranous candidiasis, pseudomembrane of oral ulcers, and morsicatio. All these things we have already discussed. This is a nutshell. For your exam point of view, you can just go through these when white lesions are asked, or acquired white lesions are asked, or scrapable white lesions are asked. Okay. And acquired lesions that cannot be scraped off with specific pattern, we have lichen planus, lichenoid contact reaction, drug-induced lichenoid contact reaction, graft versus host disease, and DLE or SLE. Then acquired lesions that cannot be scraped off without specific pattern. You have with specific pattern and without specific pattern. Without specific pattern, you have frictional keratosis, leukoplakia, oral hairy leukoplakia, PVL, OSCC, verrucous carcinoma, nicotine stomatitis, actinic cheilitis, chronic mucocutaneous candidiasis, and chronic hyperplastic candidiasis. Almost everything we have discussed. So I think you all have an idea about this. So can we go with the quiz? 1 or 2 or 3 slides. Yes, you can type in the chat box. Okay. So a 55 male presented with a white lacy area on the anterior buccal mucosa bilaterally, but could not recall since when. No ulcerations were present. Earlier, he was prescribed fluconazole by a clinician, but the lesions didn't resolve. So what is the most likely diagnosis in this condition? It's a bilateral lesion and a lacy white plaque that is present on the buccal mucosa. And fluconazole, that is the antifungal medication, was given by a clinician, but the lesions didn't resolve. So can you guess any diagnosis? Nobody is there? You can type in the chat box.
Please type your diagnosis.
I'll wait for a few minutes. Yes, Benita, Binu, and Archa has written as lichen planus. Yes, very good. Sorry. So a 60-year female was given amoxicillin clavulanate for dental abscess after drainage and presented with white plaques on the soft palate after 2 weeks. The plaques were easily scrapable with a dry gauze. So antibiotic was given and there is white plaque on the soft palate, which is scrapable. So the diagnosis is which type of candidiasis? Yes, it is candidiasis, but which form of candidiasis? Pseudomembranous candidiasis, LUHA. Very good. Now the last question. Identify this lesion. We can see the wrinkling of the mucosa as well as keratinized area that is present. It is a tobacco-related lesion. The patient keeps a quid there. Yes, archa veneta, tobacco pouch keratosis, very good. So I think you all have understood these lesions. And for the exam point of view, the differential diagnosis of white lesion is very important. And if you study the classification, you can write almost 4 or 5 questions. It is scrapable white lesions, differential diagnosis of white lesions, keratotic white lesions, and non-keratotic white lesions. Okay, so the diagnosis of white lesions vary from benign reactive lesions to more serious dysplastic and carcinomatous lesions. But there are some classic features, as we all have seen, there are some classic features that help distinguish these lesions. And as clinicians, efforts should be made to establish a definitive diagnosis to prevent the time lapse in treatment of patients with more serious lesions. Thank you. Thank you for your patient listening. And any questions?
Any doubts? No one is responding. I think they'll ask their doubts in the chat box later, the WhatsApp groups. Thank you so much, ma'am, for that wonderful session. A very vast topic was actually you have presented it in a very concise manner from a very
Actually, it is a very vast topic. I was not able to, while preparing, I didn't know how to concise it for a half an hour.
But it's very beautifully done, ma'am. And especially those pictures were very good.
Thank you.
Thank you so much. I think you can stop sharing your screen.
Okay. And all the best, dear students. Thank you.
So kindly accept the certificate as a token of our appreciation for your valuable time and effort, ma'am.
Thank you. Thank you, Nilina.
Thank you so much, ma'am.
Thank you. Shall I leave?
Yes. Shall we start the next session? Dr. Anuna?
Yes, ma'am. I'm here. I'm ready, ma'am.
Good evening, Anuna.
Good evening, Dr. Deepa. Shall I share the screen?
Yes, you can share your screen. So the next session is by Dr. Anuna Leila Matthew. She is working as a professor in Pushpagiri College of Dental Sciences, Tiruvalla. Madam has completed her BDS from COTS Mangalore and MDS from MCOTS Manipal in the year 2008. Welcome, ma'am.
Thank you, ma'am. Good evening, everybody. Since we're coming almost to the end of our sessions, I think almost all the topics have been covered. So my job becomes easier. So my topic for today is radiolucencies and radioopacity of the jaw. So since a lot of classes have been taken by previous speakers, I'm in a more comfortable position, I should say, because I need to just bring everything together and bring under a few classifications, and hope and be able to give you some insights into the radiolucencies and radiopacitities of the jaw. So the frequently asked questions from this topic is: write in detail about the anatomical radiolucencies of maxilla, then about the radiolucencies of the mandible, or it can be radiolucencies, radiopacities of the maxilla or mandible, and DDs of periapical radiolucencies, DDs of periapical radiopacities, then PCOD, that is periapical cementoceous dysplasia, and list the true periapical radiopacities of the jaw, list the false periapical radiopacity of the jaw, and sometimes even there can be questions like periapical radiolucencies associated with vital teeth and periapical radiolucencies associated with non-vital teeth and multilocular radiolucencies. I'm not sure whether multilocular comes under me or whether it has been taken previously. Still, I'll just brush through everything. Okay, these are the usual questions that we have seen in the previous question papers. So first of all, we'll see what is a radiolucent structure. Basically, radiolucent structure is a structure which allows X-ray beam to pass through it easily. So that in the resultant radiograph, it will be black in color. Same way, what is a radiopaque structure? It is a structure which is highly dense structure, which does not allow the X-ray beam to pass through it, so that in the resultant radiograph, it will be white in color. So whenever some question is asked about radiolucency or radiopacity, it's always better to define what is radiolucency or radiopacity. Firstly, you just define it and then go for classification, and then you can elaborate on each of the lesions. So that will give a better impression for the examiner that you know about it. Okay. First go define it, then go into the classification and then expand. Okay. So coming on to the classification, I'm not going very much in detail, but just classifying the radiolucencies. There can be anatomical radiolucencies and pathology. Anatomical can be common to both the jaws, or it is confined only to the maxilla or mandible. Then pathological can be associated with vital teeth or non-vital teeth. Any of these can be asked separately for your exam, a short note or a essay question. So just keep it in mind that any of these can be asked. Okay. So coming on to structures, radiolucent structures which are common to both the jaws, we have first is in the teeth, we have the pulp. Then we have the supporting structure, that is the periodontal ligament space. It is a radiolucent structure. Then we have the cervical burnout. You see bilaterally on the neck portion of the teeth, both on the mesial aspect as well as on the distal aspect. It is seen between the enamel cap and the alveolar crest. So it is sometimes mistaken for root caries. Then coming on to the anatomical radiolucencies of maxilla, we have the intermaxillary suture, we have the incisive foramen. These are the list. I'll just show you the pictures so it becomes very easy for you to understand. Okay. Coming on to the maxillary radiolucent structures, we have the intermaxillary suture, which extends from the just seen between the central incisor in the midline, which extends posteriorly. It's a thin radiolucent line. Okay. Then coming on to the nasal fossa, the nasal cavities, which are seen usually above the apex of the central incisors. They are well-defined radiolucency. They're seen on either side of the nasal septum. Okay. Then coming on to the incisive foramen, this is how it will look in a skull, and radiographically it is seen between the roots of the central incisor as a well-defined upward radiolucency. Sometimes there can be cystic transformation of this lesion, or the incisive foramen can go for an incisive canal cyst. The size is larger. Okay. This is usually seen between the central incisors, a normal anatomical landmark. Then comes the superior foramen of the nasopalatine canal. This is usually seen above the apical portion of the central incisors in a occlusal radiograph. This is the lateral fossa. This is a depression between the lateral and the canine in the maxilla. So this area usually appears as a diffuse radiolucency. This is also an anatomical structure. Then we have the nasolacrimal canal. It is seen in IOP. It can be seen at the apical region of the. Sometimes the deep angulation is given, vertical angulation is given. It can be seen above the apex of the central incisors, or otherwise in an occlusal view, sometimes it's seen on the palatal aspect of the posteriors. Then coming on to the maxillary sinus, you know, it's an air-filled cavity. It is usually seen from the distal aspect of canine going posteriorly. There can be septae, which divides the maxillary sinus into multiple compartments. Okay. So these are the radiolucent structures of the maxilla. Then coming on to the mandible, we have symphysis, the mental fossa, the submandibular gland fossa, the mental foramen, mandibular canal, and the nutrient canals. So symphysis, as we know, it is seen mostly in the midline. In infants, it will appear as a radiolucent area between the centrals, and it is seen in adults. We have to think, if you see such an area, radiolucent area between the centers, we have to think of a cleft or a fracture. Then coming on to the mental foramen, usually seen in the apical region of premolar, as a well-defined overt radiolucency. Then the mental fossa is seen in the mandibular anterior region as a depression. So that area can appear relatively radiolucent as compared to the other areas. Then we have the inferior alveolar nerve canal. It's a thin radiolucent structure extending from the mental foramen, going upwards to the mandibular foramen. So we have the superior and the inferior borders which appear radio-opaque. So the canal itself is radiolucent. Okay. Then we have the nutrient canals. They are radiolucent structures which can be seen extending from the canal going upwards, which supplies all the nutrients to the teeth. Okay, the nutrient canals also can be visualized in a radiograph. Then we have the submandibular gland fossa. This is the only radiolucent area which is seen below the inferior alveolar nerve canal. This holds the submandibular gland. Okay, so this is a radiolucent structure which is seen between the central incisor, seen from the alveolar crest region going upwards. What can it be? Any idea? You can type it. Nobody's responding, then I'll say myself, it's an intermaxillary suture. Then what can this structure be? This anatomic radiolucency be? The incisive foramen. Okay. And the next one is the inferior alveolar nerve canal and the mental foramen. Then the next short note that usually comes across is the periapical radiolucency. Coming on to the, what is a periapical radiolucency? It's a radiolucency which is seen in the apex or surrounding the apex of a teeth. So how will you classify it? I told you whenever periapical radiolucency is asked, you define about what is radiolucency and what is periapical radiolucency, then move on to the classification. Okay. You can classify periapical radiolucencies as anatomical radiolucencies and pathological. Anatomical, we have seen several periapical radiolucencies. This is the outline. Okay, these are the anatomical periapical radiolucencies. The next part is the pathological. Pathological can be associated with vital teeth or non-vital teeth. Under vital teeth, we have the PCOD, that is periapical cementoosseous dysplasia. Next is the focal cementoosseous dysplasia, can have traumatic bone cysts. The periodontal diseases can have present as periapical radiolucencies, dentigerous cysts, benign odontogenic tumors like ameloblastomas, occlusives, the lateral periodontal cysts, malignant tumors, and even tooth follicle or tooth crypt. Okay. Under non-vital, we can again categorize them into periapical radiolucencies seen in endodontically treated teeth and non-endodontically treated teeth. Okay. So first is vital tooth. Then we have the periapical cementoosseous dysplasia. In early stages of periapical cementoosseous dysplasia, there is a well-defined periapical radiolucency which is seen in the apex of the lower anteriors. The tooth will be vital. Usually patients are asymptomatic. It is an incidental finding. Okay. They're usually well-defined. Then we have the traumatic bone cyst. Traumatic bone cyst is usually seen in the posterior aspect of the mandible, and sometimes it can be seen in the anterior region also, usually associated with a trauma. And we can see, usually they are unilocular radiolucencies with scalloping borders. Then we can have periodontal diseases, which can have periapical radiolucencies. Because of the excessive bone loss, there can be a periapical pathology leading to a perioendo lesion. Then we have dentigerous cyst, usually associated with impacted teeth. It extends onto the adjacent teeth and it can present as a radiolucency below the adjacent teeth, and the teeth are usually vital. Then benign odontogenic tumors, like in case of ameloblastoma and OKCs, usually the teeth are vital. We can have multilocular radiolucencies in such cases. Usually it affects the postmandibular posterior teeth. Then coming on to non-vital teeth. Periapical radiolucency is associated with non-vital teeth. Now we have seen what are the periapical radiolucencies associated with vital teeth. Now coming on to periapical radiolucencies which are associated with non-vital teeth. First we have endodontically treated teeth and non-endodontic. Under endodontically treated teeth, we can have periapical scar. Periapical scar can present as a, usually in endodontically treated teeth, if you see a periapical pathology, periapical radiolucency, it is usually a periapical scar unless it is symptomatic. In such cases, it can be a reinfection. Or in case of surgical defect like episectomy, there can be a periapical radiolucency in a endodontically treated teeth. In all these things, we have to correlate clinically and see whether it's a reinfection or a periapical scar or a surgical defect. Then coming on to non-endodontically treated, the periapical radiolucencies are usually seen in periapical abscess, periapical granuloma, and periapical cyst. So the appearances are different. In case of a periapical abscess, it is usually an ill-defined periapical radiolucency associated with large caries teeth or large restorations, and patients will be usually symptomatic. Okay, in case of a periapical granuloma, they usually well-defined periapical radiolucency. Again, there can be a large caries lesion or a large restorations. Periapical cyst will be a larger periapical granuloma with a sclerotic border. Okay. So these are the periapical lesion radiolucencies associated with non-endodontically treated teeth. Okay. Or associated with pathology. Under pathology, we have endodontically treated teeth and non-endodontic teeth. Okay. So these are the endodontically treated teeth. You can see the periapical scar and a surgical defect. So in surgical defect, there will be a definite cut because of the surgically we have resected the tooth as well as a portion of the bone. In case of extensive periapical lesions, we have undergone episectomy. In such cases, you will be able to see. In some cases, we can see lesions which are healing also. The second picture shows a periapical scar which is healing, which usually has, some of them will have a cartwheel appearance in case of healing periapical abscess. Then coming on to radiopacity, I told you radiopacity structures are structures which are dense structures which does not allow X-ray beam to pass through. They usually appear as white areas on the resultant radiograph. So first, if you get a question on periapical radiopacities or radiopacities, define what is radiopacity, then move on to classification. This is the classification which I've taken from Wood and Gauss. So it is true periapical radiopacities and false periapical radiolucencies. So in the we have already seen the false periapical radiolucencies. They are not actually confined to the periapical region. They get superimposed onto the periapical region of the tooth. Okay. So under false, usually the anatomical structures will come. Then impacted teeth, supernumerary teeth, compound odontomes, tori, exostosis, retained teeth. We'll see the pictures, then it becomes more clear for you. Then under true, we have condensing osteitis, periapical idiopathic osteosclerosis, focal cementosus dysplasias, unerupted teeth, foreign bodies, hypercementosis. Okay, these are the true periapical radiopacities. So under the false radiopacities, we have I told you about the anatomical structures. We have the anterior nasal spine, the floor of the nasal fossa, the zygomatic process of maxilla, the nasolabial fold, the nose, and the soft tissue shadow of the nose, and the nasal septum. So this is the anterior nasal spine. can see a V-shaped radiopacity above the apices of the central incisor with nasal septum in between, usually 1 to 1.5 to 2 centimeter above the alveolar crest. So this is the anterior nasal spine, which is a radiopaque structure. Then we have the floor of the nasal fossa that extends usually from the region of the central incisors going backwards, extending to the either side of the nasal septum. Then we have the zygomatic process of maxilla, which is a U-shaped radiopacity, usually seen at the region of the maxillary posteriors. Adjacent to the maxillary sinus region, you will be able to appreciate a U-shaped radiopacity with the opening projected upwards. This is the zygomatic process of maxilla. It's a dense radiopaque structure. Then we have the soft tissue shadow of the nose, which can be superimposed on the apical region of the central incisors. So it will be a well-defined U-shaped radiopacity above the apices of the central incisors. Then we have the nasolabial fold. Because of the increased soft tissue in that canine region, you'll be able to appreciate a well-defined linear or slanting radiopacity in the region of canine premolar. That is the nasolabial fold. Because of the increased soft tissue in that region, that area appears relatively radiopaque as compared to the adjacent area seen in the canine premolar region as an oblique line. Is a soft tissue shadow. That is the nasolabial fold. Then we have the nasal septum. It's a thick radiopaque line above the apices of the central incisor. And we can see the anterior nasal spine, V-shaped nasal spine, projecting towards the sides, laterally extending. And we have the nasal septum in between. And we can see the shadow of the nose, everything we can see in this picture. Then moving on to the radiopaque structures of the mandible. We have the genial tubercle, the mental ridge, the mylohyoid ridge, the external oblique ridge, the inferior border of the mandible, and the coronoid process. You can see the genial tubercle is seen on the lingual aspect as a spine-shaped projection, which gives attachment to the geniohyoid and the genioglossus muscle. So in an occlusal view, it appears like this. In an IOP, it's a dense radiopaque structure here, and usually in the apical region of the central incisors, lower central incisors, and you can see a small dot, the lingual foramen, through which the lingual nerves and vessels will pass. Then we have the mental ridge, it extends from the premolar posteriorly. So we can see two radiopaque lines, which usually meet at the center and extending posteriorly. This is the mental ridge. Then we have the mylohyoid ridge, usually at the level of the molar apices. You'll be able to see a well-defined radiopaque line, and it is usually seen above the mandibular canal. Then you can have the mandibular canal, the superior and the inferior border of the mandibular canal, they appear radiopaque. And in the center, then you can have the inferior alveolar nerve canal. Then we have the inferior border of the mandible, which appears as a thick radiopaque line. Beyond that, you will not be able to see any structure. That is the inferior border of the mandible. Then moving on to the next. That is, we have seen the classification. If you remember the classification, under false periapical radiolucency, we saw about the anatomical structures. Then moving on to the impacted teeth, supernumerary teeth, and odontomes. So impacted teeth can usually appear as a false radiopacity above the apices of any of the teeth. Can be central or lateral. Usually canines are impacted, so it can be seen in the apical region of the centrals and the laterals, especially in the upper anterior region. Then we can have supernumerary teeth, and compound and complex odontomas can also present as false radiopacities. Okay. The first one is a compound odontome. Then tori. Tori or exostosis can also be presenting as a radiopacity in the either in the maxilla or the mandible as a false periapical radiopacity, and peripheral osteomas can also be seen as a radiopacity. Then retained root of the adjacent teeth can be seen superimposing onto the apical region of the adjacent teeth. So that is also a false radiopacity. Then foreign bodies, either it can be a foreign body which is present either on the buccal or on the lingual cortical plate, or it can be a foreign body which is present in the upper lip, can get superimposed on the periapical region of the teeth. Then mucosal cyst of the maxillary sinus, which is usually seen as a dome-shaped radiopacity in the maxillary sinus, which get superimposed onto the periapical region of the maxillary molars. That's a mucus cyst of the maxillary sinus, mucosal cyst. Then coming on to the true radiopacities, that is radiopacities which are present on the apical region of the teeth. We can have condensing osteitis or sclerosing osteitis, usually associated with caries teeth. This is a case of rarefying and condensing osteitis. Usually condensing osteitis will be a well-defined radiopacity associated with grossly decayed teeth or teeth with large caries lesion and or large restorations. You'll be able to appreciate a well-defined increased area of radiopacity in the periapical region. Sometimes you'll be able to appreciate rarefying, that is radiolucency, with on the periphery you'll be able to appreciate the radiopacity. So it's a mixture of rarefying and condensing osteitis. Then idiopathic osteosclerosis, usually there is no cause for it, but it can be seen in the periapical region of premolars or molar region as a well-defined radiopacity, so which is present in the periapical region or sometimes little below the periapical region of posterior teeth. You can call it as periapical idiopathic osteosclerosis. Then unerupted or succedaneous teeth, that is usually if the permanent has not erupted and if they are retained, they can be seen as a well-defined radiopacity below the apices of the deciduous teeth. Then next periapical radiopacity is mature PCOD or FCOD. That is, I told you periapical cementosus dysplasia have three stages. We have the initial stage, we have the mixed stage, initial stages, radiolucent stage, mixed stage, we have both radiolucency and radiopacity. In the mature state, it is a well-defined periapical radiopacity. So in such cases, a mature PCOD can present as a well-defined periapical radiolucency, and FCOD is again a form of PCOD, but it is seen usually in the posterior region. As you can see, it's like a horse-shaped radiopacity can be seen in the posterior region. It is usually confined to one teeth, or even florid osseous dysplasias also can present as radiopacities in the periapical region, but florid means it will have a flower-like appearance. Will be multiple radiopacities will be seen both in the upper and the lower arches. So that is a case of florid cementosseous dysplasia. So a mature PCOD or FCOD or florid cementosseous dysplasias can present as radiopacities in the periapical region. Then again, we can have foreign bodies. They are actually, some of them are true radiopacities. They are seen in the periapical region either because of overobturation of the respiratory materials or gutta percha, or in case of retrograde amalgam filling, you will be able to appreciate well-defined radiopacities in the periapical region. Like in the first case, it's a extruded obturate material gutta percha, or in the second case, it is like a retrograde amalgam filling, which is there in the periapical region of the central incisor. Then in case of hypercementosis also, you can have well-defined radiopacity in the periapical region. Usually in cases of teeth which are subjected to high occlusal forces, you will be able to appreciate periapical radiolucency. In case of Paget's disease also, you will be able to appreciate hypercementosis of teeth. So we have seen almost all the periapical and the periapical radiolucencies as well as periapical radiopacities of the jaw, both including the anatomic structures and the pathologies. Anatomic structures we have seen both in the maxilla and the mandible, and common to both the maxilla and the mandible. And in case of radiopacities, we have seen the true radiopacities and the false. Under the false, we can have anatomic structures, and the other structures under true, we have seen multiple radiopacities. So it is so coming on to the conclusion part, we should be able to differentiate between the true and the true periapical radiolucencies and the false ones. And you should be able to, whenever such a question is asked, you should be able to define it, classify it. First of all, define, then classify, then list them, depending on the marks that is allotted for you. If it's a major question, then you have to explain everything in detail. Otherwise, you can just list it and write a brief note on each one of them. So that should be able to, so with that, you should be able to get good marks. So that's all from my side. If you have any doubts.
Any doubts? Thank you so much, ma'am.
Thank you, ma'am.
There is there is a doubt in the chat box.
What's, ma'am? I'm not able to say it. Can you see?
Ms. Najia has written, as age advances, symphysis fused and seen as radiolucent line.
Chat box, okay.
Yeah.
Usually it is seen in, usually I have not seen much cases.
No, it usually is not seen as a radiolucent line in adults. And the symphysis
In
is
this,
usually seen in the
simple usually
infants. Yeah.
in infants only.
Yeah. I think that clarifies our doubt.
Yeah. Okay.
Further doubts, do post in the WhatsApp groups.
Okay, ma'am.
Thank you so much, ma'am. Again, this was a
Thank
very
you.
extensive topic, and you have made it very concise from an exam point of view. Thank you so much.
Others made it easy for me because everything has already been discussed. So I
Yeah.
just had to mention the name.
So as a token of appreciation, kindly accept our certificate.
Okay, ma'am. Thank you. Thank you so
Thank you
much,
so
ma'am.
much.
Okay, ma'am.
So I think we'll wind up today's session. Thank you all for joining. Thank you.
Okay. Thank you, ma'am. Thank you, ma'am. Bye.
We'll end today's session now. Thank you.